சொல்லுங்க சார்.
Good evening, all, and welcome all of you for this month's TNIG meeting. I request our President, Dr. Ramasubramaniam, to give the welcome address. Over to Dr. Ramasubramaniam. Inker, please mute everyone except Dr. Ramasubramaniam.
Good evening to everyone. We welcome you all for this monthly meeting of 2021. Can you hear? Hello?
Yes, sir. Yes, sir. Go ahead.
Hello? Hello,
Sir, we
can you hear
you,
me?
sir. Yeah, sir. கேக்குதுங்க சார், பேசுங்க.
Good
Ramasubramaniam, you are audible. Go ahead.
Okay, thank you. Good evening, everyone. I welcome you all for this monthly meeting for June 2021. And we have quite an interesting cases lined up for presentation today, followed by topic of the season now, COVID-19. And I request the first presentation to start.
Inker, Vikram, please. Inker, there is some noises in the background.
Search பண்ணிட்டு இருக்கேன் சார். There is TV program going on in the backstage.
Inker, mute everyone, except the presenter. Now ask the presenter, Vikram, to share the screen and start presenting.
Sure, shall I start, sir?
Yeah, you start.
Thank you, sir.
Sir, TGV, sir, you will give an expert comment after his presentation.
Yes, sir. So can you see my slides, sir?
Yes, Vikram, go ahead.
Good evening, one and all professors, friends and colleagues. Today I am here to present a lemon on a matchstick, an interesting case of ectopic ACTH producing tumor. I am Dr. Vikram from SRMC Hospital, Srihar. So our patient was a 50-year-old female with comorbid conditions of diabetes mellitus, hypertension, rheumatoid arthritis, and hyperthyroidism, who was referred to us from outside hospital with complaints of fever, altered speech, oliguria, and profound weakness of muscles. She was initially admitted in the endocrinology department of our hospital, and she was bedridden under ICU care for a week before referring to our place. On initial clinical examination, she was obese with a moon-like facies with multiple ecchymosis all over the skin, diminution of vision due to central serous retinopathy, persistent hypertension, refractory hypokalemia, which was not responding to treatment pertaining, showing us a diagnosis to be a Cushingoid syndrome. So this was a patient who had the typical Cushingoid features of moon-like facies with buffalo hem, obesity, with ecchymosis spots present all over the skin. So her initial hypercortisolism was diagnosed with a 24-hour urine cortisol level found to be significantly high, around 2,736, with the normal being only 10 to 80, followed by which differentiation between whether ACTH or non-ACTH dependent, she was found to have high ACTH levels of 180 picogram per ml, and following which a high-dose dexamethasone suppression test was done, which found no response at all. There was still high cortisol and high ACTH level. So further, we did imaging to localize the production of the ACTH with the MRI brain, which showed a normal pituitary gland, and also a CT abdomen, which showed a suspicious lesion in the D1, D2 junction with bilateral bulky adrenal glands. Further, for further localization of this ectopic ACTH producing tumor, we did a gallium Dodeal PET CT scan. It showed gallium uptake in the second part of duodenum as highlighted here. And further 2 lesions were seen just outside the duodenum, one on the anterior surface of the pancreas and another at the D3-D4 junction. So here in the cross section, you can see that. So this was the lesion within the duodenum with another 2 lesions, one on the anterior surface of the pancreas and another at the D3-D4 junction, showing gallium uptake strongly. And nowhere else any uptake was seen. A further UG endoscopy showed a submucosal lesion in the D1-D2 junction. This patient was diagnosed as an ectopic ACTH producing tumor, and hence she was taken up for surgery with preoperative treatment with ketoconazole and spironolactone. Stress dose steroids were given, potassium supplements were given, hypertension was optimized, and she was taken up for surgery in the form of a transduodenal excision of the tumor with lymph node excision. So intra findings showed a 1 centimeter submucosal growth in the proximal part of D2 with 2 lymph nodes significantly enlarged, one on the anterior surface of the pancreas and another at the D3-D4 junction. And all these 3 lesions corresponded to the lesions picked up by the gallium scan. So this was actually the intra picture. So duodenum with 1 lesion showing anterior to the surface of the pancreas here. And this was the second lesion at the D3-D4 junction in the retroperitoneal region around 2 × 3 centimeters. Duodenectomy was done, which showed a 1 centimeter submucosal lesion, which was also taken out. So these were the final specimens, with the first being the duodenal submucosal tumor, with the other 2 being the regional lymph nodes. And the surgery was actually planned to be only a local excision with lymph node excision, as the patient was highly dependent on steroids, and hence we thought of arriving at a diagnosis and doing any further workup. So this was the histopathological examination showing a well-differentiated neuroendocrine tumor, lesion being 1 × 1 centimeter, grade 1, mitotic rate of 2 out of 10, 2 per 10 high power field, Ks67 being 1% with lymphovascular and perineural invasion, and both the lymph nodes are also positive. The immunohistochemistry showed a positive for bimentin, synaptophysin, chromogranin, and ACTH. So this was the histopathological slides showing the classical neuroendocrine tumor appearance of salt and pepper chromatin, with further immunohistochemistry staining showing positive synaptic chromogranin and ACTH, with Ks67 uptake of only less than 1%, thus showing an ectopic ACTH producing neuroendocrine tumor. So this patient was on follow-up. As you can see the difference, 3 months later, the same patient had reduced significant weight. Her moon-like faces disappeared. Her hypertension and diabetes got resolved completely. She lost 20 kgs of weight. Her myopathy also completely resolved. ACTH and cortisol levels returned to normal. Her vision was also improved. So this case we are bringing here today for discussion. So Cushing syndrome refers to a complex of symptoms and signs due to hypersecretion of cortisol of any cause, of which Cushing's disease refers to hypercortisolism because of a pituitary tumor. This is being the physiology of HPA axis. So due to endogenous or exogenous stressors, there is stimulation of the hypothalamus releasing to CRH or corticotropin releasing hormone, which acts on the anterior pituitary to secrete ACTH, which in turn stimulates the fascicular region of the adrenal cortex to secrete cortisol. And this has a negative feedback mechanism on anterior pituitary and hypothalamus. So arriving at a diagnosis of hypercortisolism as well as localizing it. So first, to confirm the diagnosis of Cushing's syndrome, we do either an overnight low-dose dexamethasone suppression test or a 24-hour urinary free cortisol level or a 11 p.m. salivary cortisol. Our patient had 24-hour urinary free cortisol high of 2,736, just proving to a case of hypercortisolism. To determine the source of hypercortisolism, to define whether it is ACTH independent or dependent, we did a plasma ACTH, which was in our case found to be significantly high. And also to localize the tumor, we did a high-dose dexamethasone suppression test, which showed that no response to this test, hence proving that if there is lack of suppression, then it is the source of an ectopic ACTH source, which should be localized with a gallium dotatate scan. So our patient was also initially done an MRI brain, a CT abdomen, followed by a gallium dotatate scan, and then only proved to be an ectopic ACTH source of a duodenal neuroendocrine tumor. And dexamethasone suppression test. So low dose is done to diagnose only Cushing syndrome. But to localize the tumor, we do a high dose dexamethasone suppression test of 8 mg is given. If there is a response with low cortisol, that means that it is a pituitary origin. But if there is still the cortisol levels are high, but low ACTH becomes low, that means that it is a local adrenal cause of thing. But if there is no response at all, that even in spite of giving high dose dexamethasone, there is high cortisol as well as high ACTH. That means that it is an ectopic source. Our patient was having an ectopic ACTH. So coming to the Cushing syndrome's origins, it is defined as ACTH dependent and ACTH independent. ACTH dependent being 90% of the time more common, with 75% of the time being a pituitary microadenoma more common, with 15% being an ectopic ACTH producing tumor, more commonly carcinoids of the bronchus, thymus, and pancreas, followed by advanced small cell lung cancers, followed by medullary carcinoma thyroid, followed by pheochromocytomas. The 10% of ACTH independent Cushing's mostly arise from adenocortical adenoma, followed by adenocortical carcinoma. Very rare causes being the Carney complex PPNAD, as well as AIMAH, as well as McCune-Albright syndrome. So this was a study done by the MD Anderson Cancer Center, trying to find the source of the ectopic ACTH producing tumors. They found that these tumors most commonly arise from the chest cavity, being a bronchial carcinoid or a small cell lung cancer, around 41%, and they couldn't find the source of these ectopic ACTH almost 9% of these patients. And in a series of manuscript and previously published case series, bronchial carcinoids are the most common cause of ectopic ACTH, followed by small cell lung cancer, with the gastroenteropancreatic neurodegenerative tumor being only 13%. Now coming to the duodenal neurodegenerative tumors. So these are also quite rare. Of all the gastroduodenal GI neurodegenerative tumors, they comprise only less than 4%, more commonly being gastrinomas, and they are usually less than 5 millimeters in size, and exception being multiple in men 1. And they frequently localize to the regional lymph nodes. Hence, regional lymph node sampling is always advised in a duodenal neurodegenerative tumor. And coming to the incidence, you can see that ileal and jejunal neurodegenerative tumors are most common, followed by rectum, and duodenal neurodegenerative tumors are quite rare. As well as coming to both neurodegenerative tumor of the duodenum with ectopic ACTH production was previously published in only 3 case reports, as highlighted here. And coming to the grading, any neurodegenerative tumor with more than 20 mitosis per 10 hypa field with Ki67 more than 20% is considered as poorly differentiated, and anything less than that is well differentiated. And coming to the Hcc staging, our patient had this T1 tumor with tumor being invading only the mucosa, some mucosa, and is less than 1 centimeter in size, confined to the duodenum, with regional lymph node involvement being of 2 lymph nodes, hence N1, with no distant metastasis, so M0. So it was a stage 3, NET N1 M0. And localization of these neurodegenerative tumors is initially done with an abdominopelvic multiphasic CT. If not found, then you go with a somatostatin receptor-based imaging, a gallium dotatate PET CT, followed by UGScopy or endoscopic ultrasound, followed by CT chest. So coming to the treatment of duodenal neurodegenerative tumors, if it is a local regional disease only, you can do an endoscopic resection or a transduodenal excision of the tumor, or a Whipple's, a pancreatic duodenectomy. If it is a metastatic advanced disease, if it is well differentiated, you can do a debulking surgery or a somatostatin analog, or PRRT can be tried. If it is a poorly differentiated tumor, you can directly go to chemotherapies based on platinum-based chemotherapies or immunotherapies, sunitinib and everolimus. So conclusion, so this case has been discussed today because of its rarity. The rarity being the incidence of duodenal neurodegenerative tumor being only less than 4%. With these duodenal entity with ectopic ACTH being published only 3 times previously, 3 case reports, and hence the localization more favoring a gallium dotatate scan. And if this lesion is found in a duodenum, you do a local excision with a adjacent lymph node sampling, as recommended for less than 2 centimeter tumor lesions. Thank you.
Thanks, Vivek. Dr. T.G. Balajinder, sir, your expert comment.
Can you hear me?
Yes, sir.
Yeah, yes, sir.
Yeah, it's a very good presentation, and I'm surprised. It's a very rare presentation as a case of neuroendocrine tumor, actually. In my experience, I have seen neuroendocrine tumors like gastronoma from the gastronoma triangle. I have seen neuroendocrine tumor of insulinoma cases from the body antecedent process tail. And but the first time I'm hearing a case of a neuroendocrine tumor producing a ACTH, causing an ectopic Cushing syndrome. So I think the duodenal neuroendocrine tumors, they comprise about 2 to 3% of all the GI neuroendocrine tumors. But nowadays we are able to delineate these and find out some of these patients, because of when the patients are being investigated, they turn out to be incidentalomas, or sometimes these patients, they produce these tumors, they produce some kind of hormones. So in which we are able to, they produce some kind of paraneoplastic syndrome type of pathology. So the patient comes with Cushingoid faces, as he has described, Lebanon matchstick appearance. That is, there is a, or it can also be called as Lebanon toothpick appearance, in which there is a central obesity, the wasting and peripheral upper extremities and the lower extremities. So the one thing which I'm surprised that the literature says that most of these ectopic Cushing syndromes, they are usually they are very quite malignant when they are when they are diagnosed. Most of these patients, they have metastasis into the lymph nodes, into the lungs, or into the liver, and something like that. So more than 50% of these patients, they have metastasis at the time of diagnosis. Of course, it's an advantageous of these such patients as compared to the non-functioning tumors, wherein these patients are discovered late because they don't secrete any amines or any precursors. So these are the patients, the non-functioning tumors, they grow in such a large, so they go and cause pressure effects to the adjacent organs, or they may even become malignant and they go later on. So these are the pictures. But as of now, there are no clear-cut evidence of treatment guidelines or the diagnostic guidelines described, because there are only case reports described and there are some case series described. Of course, WHO has